Clinical goals of Estim currents. This one may be a little bit longer than the videos I like to, the time limit I like to keep them to, just because there's a ton of information. And so get ready, have your book. You have your book ready right here. We're now in chapter 12. Read that. If you read that, you're gonna cover stuff that we've covered in class, and so hopefully it'll be reinforcing. This will help. I know it's kind of this antiquated, read a book. Yes, read the book. Have the note pages out, go through this. I'll go as quick as I feel possible in this video, and then hopefully when we get to class, you guys have some questions, or you guys want to, even if it's something you kind of think you understand but you just want to make sure, ask that question. If you have no idea, like, what the is this, yeah, ask that question. I want questions in class so we can talk about this stuff. That means you're engaged, that you're interested in learning this stuff. All right. So we will start. Let me get my face out of here because that's not good. In fact, I don't even need a small face. Let's just move you out of here. Home jibs. I'm gone. All right. So let's go with a couple of fun pictures. Some people, like Matt, may feel like e-stim currents really don't, add to patient care. So the clinical utility of that is like, it's a bunch of, but I tend to disagree. I think there's some use for them in certain situations. And so hopefully I like to think of it like this, like Thor finally figured out his whole power, and now he's ready to go rock the world. That's what I want you guys to feel like. You guys are going to be ready to rock the e-stim world after this. All right, this is not why my videos are going to be so long, so don't worry about that. All right, this first one is just and you have this in your handout. This is just kind of the intro slide. Look, muscle contractions, pain control are two things that we know STIM does. You can't argue with that. The argument comes in is it helpful to the patient care and to their outcome? That's the one that's up for debate. But we're talking about, so we're going to break these down into the muscle contractions, and there's some other ones that I'll throw in there, but muscle contractions are where we're going to start. So I mentioned this, I think, in class, but I think this is a good slide just to compare and make sure you have a good idea between the differences between a physiologic voluntary contraction of a muscle, and then when we place a pad on a specific spot in the muscle over a specific motor unit and say contract over and over and over and over again at the same exact way. Right, so make sure you have it. You need to be able to give me the differences between physiologic and electric ones. So I don't know how you designate importance. This is that slide to designate importance. As you study, stop on this slide and make sure you know the difference between physiologic, electric. These bullet points are all good, not just one bullet point. I'm not going to play favorites here. I love all my kids, right? Yeah, right. Sorry. All right. Then I have a couple slides. Again, this should be, right? So this slide right here, as you read these bullet points, it should be, I remember polarization, and I remember the depolarization parties I've been to in undergrad. Yeah, we talked about that. This is just the basic stuff. So I just wanted to kind of get that out there. The new part is this, right? That depolarization, it says occurs. You can change that to is most likely, because under the cathode, which is the negative in our world. So if to get a muscle contraction, the best chance is to put the negative electrode over that specific muscle that you want to contract. If you put the positive, or it doesn't mean you're not going to get a muscle contraction. I'm getting excited. I got to slow down. Doesn't mean you're not going to get the muscle contraction under the anode or the positive pole, but it's just better. So as you set your treatments up, then you want to look at, all right, where's my negative pole? If I'm trying to get a contraction, let's put that on the muscle or where I want it to get contracted. Your book does talk about this in chapter 12. It gives you a lot more specifics than I'm giving you, and actually gives you like the actual pulses per second and all. But here's the deal. You just need to know this, that the larger diameter nerves, they don't need much stimulation to depolarize. When you think back of what kinds of nerves are larger diameters, those are A beta, A alpha, those are sensory nerves, right? And so when we turn this stim up, we immediately start feeling tingling. And it doesn't take much for those sensory nerves to go, hey, I'm depolarized. There's something going on. I got tingling over here. And so that's good, all right? And then as the larger nerves need a little bit more stimulation, or deeper nerves, as we turn the intensity up, we know it goes deeper. But then I think I even mentioned this little bit. Yes, pain receptors and fibers, C fibers, they're superficial, but typically they have a little bit higher resistance to current flow. And so we definitely get sensory input first, or sensory activation. But a lot of times we'll also get the, not all the time, but a lot of times we can also get motor nerves that are deeper. We can get them to depolarize before the pain nerves start to know what's going on. So it's like, shh, don't wake up the pain nerves. And we're just gonna contract here. So, and that's different on each person and each area. We'll figure that out as we start playing with these things here. As we go into, oh no, come on. This is again just kind of the follow up to kind of what we know about muscle contraction and that depolarization stuff. That hopefully I'm just reiterating. This is in chapter 12, but ultimately once we get depolarization of that neuromuscular junction, then we get that contraction of the muscle. So that's all that is really. So I don't want to spend much more time on this. This is where I do want to spend time on, and this can be confusing. So heads up, but I'm going to try to make it as least confusing, as little confusing. I don't know. I'm going to try to make it, pretty reasonable. So this information starts, I'm going to give you a page 247. That's where it starts. And actually, the section starts at 246 at the end, but then it starts talking about really the stimulation levels. And that's what the strength duration curve is used for, is to kind of compare different neurons. I don't know why I said it like that. I was going to say nerves or neurons, but different types of neurons and how much the stimulation has to be to depolarize those. I do want you to look at 47. There's a couple definitions that talks about motor level stimulation. I want to point your attention to the noxious level. Noxious is pain, right? And so there sometimes is a clinical goal of using Estim to induce pain. Like, why would you do that? We'll talk about it. It'll come up. So, but let me put up my pictures. If I can get my computer to put up my pictures. So this is a strength duration curve. You have a more elaborate one, and I do too coming up, but you have the more elaborate one on page 248 in figure, what is that, 1211, has a bunch of different lines on this. Ultimately, what you're looking at right here is if you look at how long you're going to apply a stimulus or a electrical current. So this is, obviously you see down here, this is duration of current, and we can call this, just to make it easy, let's call it seconds, right? We're going to apply this for a certain amount of seconds. This is how high or how much we turn this up, or what the intensity is. There's two things that I want you to realize here on this graph here, is this concept of real base and chronaxy. And so I'm going to put up the definitions. You have the definitions. And so when I look at the real base, look, if we're going to apply this, so if this is at 5, what is this, milliamps, or just 5 milliamps, all right? So if this is at 5, our intensity is at 5, and nothing happens, and then finally something happens at that same intensity, right? So that's going to be our real base. Then what we do is whatever that is, so we go, if it was like just under or just over 4 seconds, then our, 2 times that is this chronaxy. These are just points. So you're like, do I really have to know this crap? So here's what you have to know about this. You have to know that these two things are terms that exist on the strength duration curve, and these are measures that are used to compare motor nerves. And so as I put the next one up, this looks like, or this is what you have, or similar in the book, right? And so here's what you see is that what you're looking at is all these different motor neurons. So here's not motor neuron. Here's a motor neuron. This is sensory. This is A delta, which is the pain fiber. This is a C fiber, pain fiber. So all this is telling us right here is that basically, if we wanted to stimulate A beta, if all we're looking for is sensory gate control stuff. We just want it to tingle and give you a nice tingly feeling. All we have to do is turn this up to 40 milliamps on this one, and we're going to get a reaction right here. That's that chronaxy, but it's not labeled on this one. Don't worry about that, but that's what's used to measure. These are all the chronaxy points. So this is what we're going to compare. And so here's our chronaxy. We only have to apply it for now 100 microseconds, and we're going to get this A beta to depolarize and feel tingly. If we keep doing that, right? If we keep that up, if we keep the intensity at 40 milliamps and we go here, C fiber's never getting involved. We never get the C fiber going, right? If we turn this thing up to 120, yeah, A beta is still going because we've already, depolarized it right here. It's just more intense. We're going to get the motor nerves to go. We may get some A delta, so it will start to get, and we have to apply it for a very, very long time to get those C fibers going. But basically, we would have got the A delta, so I shouldn't even said the C fiber. But if we turn it up to 80, right? Let's say if we turn it up to 80, then that's where we're going to start to get some pain. Well, we don't have to turn it up to 80. Look, we can just keep it at 40. No, the pain nerves don't even know we're here. Oh, we want to contract? Well, let's turn it up to 60. Come on, the pain nerves won't even know we're here. Why is he talking like this? This is annoying. I don't want to listen to this. All right, so I'll talk normal. Anyway, here's the outcome. What I want you to know about chronaxy is that's the measure. You can know what it is. It's 2 times wheelbase. But ultimately, that's what's used to compare different neurons and how they respond or what their threshold level is to electrical currents. And so when you look at this shorter duration stimuli, so this is the 2 takeaways right here. So if I'm only going to apply this for a short duration, I got to have a little bit higher intensity to reach the threshold. And typically what we've seen is that the high intensity short duration currents are very effective at either accomplishing sensory stimulation, motor stimulation without the pain, right? Sometimes even, like I said, sometimes we want noxious, but anyway, so that's what's going on. All right, so I'm going to move on from the strength duration curve. I'm expecting some questions on this, but it's really, if you just kind of focus on these 2 takeaways right here, I want you to know the 2 takeaways. We're comparing them, and that's about it. I'm not going to ask you to explain this graph to me, other than just the takeaways. All right. All right, so let's keep going as we move through there. Hopefully you've heard of the all or none response. I'm not going to go over that. You can read that. That's a anatomy physiology concept or even biomechanics concept. What I do want to focus your attention to is when we talk frequency, right? And I mentioned this a little bit when we talked about summation, but when we talked about frequency, when we have lower pulses per second, we get much more of those twitch contractions, twitch, twitch, twitch. As we start to get higher, as those pulses come quicker and quicker, there's not enough time for those twitches to go twitch, relax, twitch, relax. You can't do that because there's not enough time. It's it's being bombarded by all these electrical pulses. So now what happens is you get twitch, 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 contract. And it's just hold until the electricity goes away. All right, I'm getting excited again. So that's on there. Make sure you have a good idea of that. As we start to get into now, how are we going to use these muscle contractions? What are we can do all these muscle contractions. We've seen in our clinic, we have done this from time to time. Muscle re-education is a common clinical goal or clinical use for electrical stimulating currents. You have an injury, you have neural inhibition. It's really, really common after surgeries because we're like cutting into the, we're having, it's much more of a injury that occurs. So it's much more common in when we start sticking utensils into a joint and moving stuff around. So we get this, and that's why right after surgery, you go contract your quad and it's just it's not there. Or it's very, very weak, right? So there's some neural inhibition. And so that's what this is about. So the whole point here is to provide some external stimulation to contract the muscle. And then what we do is we use this as feedback to start to train those voluntary, impulses yet again. And so that's ultimately what we do is we, and it can be done either way. So you can have it as the Estim contracts them and turns on and contracts the muscle. You can have them try to contract with it. Ooh, my muscle's contracting. I will try to contract too. Or what you can do is let the E-stim contract, and then on the off cycle, the person then tries to recreate that and tries to make that. So either way is acceptable, and I've seen that. So just beware that there's either way. We typically do it along with it here at our clinic. I think Matt still does it that way. This is a good slide. This is a good slide for your practical stuff. So this kind of tells you, as you start to set up the machine, this is starting to give you some details. Our pulses per second, we want to be basically below 40, right? The lower we get, the 10 is going to give me a more twitch contraction. Closer to 40, it's going to give me a more tetany type contraction, where it just contracts and holds. Either of these will be fine. So either of these will be fine, and you can use it. The surge, so it's going to go on-off times. You're going to have some on-off times. And this is important right here. So for the classic, right, for the classic descriptor, or the classic, textbook way to do it, because we are stimulating the same motor unit over and over and over and over, fatigue is going to be a factor. So we want more off time than we want on time, and that 4 to 5 is the guideline. I hate it. I don't use it, but you need to know it. And so for class, you're going to set it up like that. We'll talk about that in when we're face to face as we go. All right. As we go through other things that muscle contractions can do, just think about, if we just do some twitch contractions, what about the edema? If we have, check this out, if we have a lot of edema around this ankle, which we don't because you can see the malleolus, but say we did, pretend, I couldn't get a good picture. Pretend there's a lot of edema right here, and we want to get rid of that edema. They're not weight bearing yet. And they're, we're trying to get some contraction. One of the ways that we can get rid of edema is through muscle contraction. As the muscles contract, it starts pulling on those lymphatic vessels and valves, and so that kind of lets the lymph fluid kind of flow into them. We want to do that. We want to contract it. And so if we can just sit there and twitch back and forth, then that's kind of the theory that may help do that. You put them in some elevation, you contract the muscles. Here's the thing I want you to realize, and I'm going to even put here's what I'm going to do. I'm going to put my face in there now. Look at this. This is how serious this is. When, I was going to say if, but when you do this for class, if I give you an ankle and say, hey, we're going to do a E-stim to get rid of edema, and you go, man, I want to contract some muscles. If you put your pads right around the ankle injury site, what are you contracting? You're not contracting the ligaments. You're not contracting the malleolus. So that's why that's why I picked this one, because you see this person right here putting the pad. She's going to contract the gastrocsoleus. So we get some plantar flexion. We get some movement in that area, and yes, that hopefully kind of helps. Anyway, so you can see that I do want you to, the actual protocols, the pulses per second are still going to be in that 10 to 40 range, probably a little bit more down to the 10 range, right? Let's get some more individual contractions and do that. And then we want to bring the on-off times similar, because we're really trying to maximize the contract, relax, like the pumping. We're trying to, you'll see this, I think the book even says muscle pumping. You're trying to get this pumping action, and if we only pump once a minute, we get 10 seconds on and then 50 seconds off. Well, dude, we get, in 20 minutes, you only get 20 contractions. We want, a little more on, off. So a lot of times you'll see 10 on, 10 off, or 5 on, 5 off, that kind of stuff. We'll talk about that too as we get going in class. The other thing, so we got muscle re-education, yay. We got getting rid of edema for muscle contractions. And number 3, we got, oh, come on, work. I got it. Excuse me. Yeah, we got spasm. This is one of my favorites, you guys. This is really one of my favorites. The whole theory here is, all right, we got to be, first I just told you, hey, be careful because you might fatigue the muscle. It's going to contract the same motor units over and over. But now, when we have a muscle that is spasming, that's already there, Then what we do is we put the pads on there and we contract it even more to try and fatigue the muscle so the muscle just relaxes. This is the classic, you want something to cry about? I'll give you something to cry about. I don't know if your parents ever told you that. Mine did. But it's like, oh, so you want to contract? Okay, well, I'll give you something to contract about. We'll see how you like this. And hopefully, I mean, that's the goal. Whether how effective it is, I've seen it be effective sometimes. I've seen it not work other times. So, you know, I haven't really logged the numbers, but sometimes it'll work, sometimes it won't. But that's the theory behind doing that. And so, as I put my face out of the way so you can see that, again, our protocols are very similar, but now we want to make sure that our pulses per second are on that high range, right? And so we want to have contracting and spat, you know, we want the tetany type contraction. We want that muscle to contract and hold, baby, and get fatigued. Let's, do we have to have the 4 to 5 times off versus on times? Heck no. We want that muscle to fatigue. So we are gonna have some on off times, but anyway, all right. All right, so this is already getting longer than I really wanted this one to get. And I know I know what's coming next, so there's still a lot more. So I am going to do a part 2. I know it's getting too long, so it's like it's time to go. So let's stop this one, and I'll give you a different one in here in a second.